in the studio of TheInformer, we have Professor Tony Costello, who's been a 50-year veteran of surgery, a man who not only understood just how difficult and complex things could be in the theatre, the operating theatre, but who also saw a way to decide that there was a better way to do things. And you weren't afraid of all these new technologies and new techniques. When did you think that maybe robotics is the way forward?
It's a bit of a journey. Would you like me to tell the story?
Sure, go ahead.
So I went to MD Anderson, which is the big cancer hospital in Houston, Texas, and trained there and learned how to do operations such as testicular cancer surgery. And I was a footballer and I watched Peter Crimmins die from testicular cancer and had his lungs irradiated and then passed away because there was no treatment. There were bad treatments for testicular cancer, but no curative treatment. And I went to the US, and the same disease with the same young men as Peter Crimmins, they were giving chemotherapy to, and they worked out the cocktail of chemotherapy, and they were going, brain metastasis would go away, all their disease would go away with this chemo. And I thought, this is just truly
So
marvelous.
had we had it here, it could have
No,
been
we didn't have
different.
it here.
No,
So
had we,
yeah. Well, he was a year or two too early. So
wow.
thereafter, very few men die from testicular cancer, even when it's spread widely through the body because of the effect of chemotherapy. So I thought, gee, this is good. And then I was taught how to do these really big cancer operations, removing bladders very safely, and that was the mantra there. No one would die from surgery, So we did 500 straight complex bladder surgeries without any mortality, which was a 25% mortality where I came from in Melbourne. So I thought, gee, this is good. And then we used to do this operation of radical prostatectomy. The earliest prostatectomy operations would make a cut. And that was where it was a complete bloodbath because we didn't understand how to control the bleeding. We were cutting bits of the pubic bone away to try and get access. They were very brave patients, those guys. And they were in hospital 3 weeks and had, losing up to 20 units of blood. And so that was...
But many of them wouldn't have had another option, would they?
Well, the option was, then it was removal of both testicles. So when confronted with that choice, some men they're very attached to their testicles.
I was just going to say, I can remember the decision by Angelina Jolie to take her breasts off, and as did another couple of members of her family, her sisters, because of her mother's journey.
Hereditary breast cancer.
Correct.
And it's that same gene is very involved in hereditary prostate cancer, the BRAC gene. So we're looking very hard at genomics and prostate cancer risk. So people who are Ashkenazi Jewish, European Jews, have a much higher incidence of prostate cancer from their BRCA risk. So it's not just breast cancer, it's ovarian cancer, pancreatic cancer now we know, uterine cancer. So a lot of different hereditary cancers we're understanding, and then tailoring therapy by targeting those genes to switch them off.
Gotcha.
So it's continuing to evolve.
The journey of discovery continues for medicine. So when did you think we need some assistance?
Yeah. So this was not the way to go, I thought, and I did that.
Too much blood.
Wow. Well, it was very morbid, and the poor patients were in hospital 3 weeks. But I did some when I came back, and then I went back. I did so after about 6-7 years in practice in Melbourne. I thought, is that all there is? I need to do something different here. This is just not going to be the rest of my life. So I went back and I did sabbatical at MD Anderson in Texas. Took the whole family, set up, and then I went to the animal laboratory there and I started fiddling with lasers, and some physics guy out of the University of Texas said, what do you think of this? So he had a laser where he could bend the light at right angles, which the first time off a gold tip. So then we were fiddling with putting it into the prostate, so I started working on benign prostatic.
Picking a target and taking it out.
And then we were treating prostates with laser rather, and it was less bleeding, and I wrote a PhD on that, and we did the first cases in Melbourne of laser prostate surgery, which is now 50% of surgery for benign prostate is now laser. So we did some good early stuff, and then at the same time I looked at laparoscopy, which was just starting, and we started up laparoscopy, but we did it, and I thought it was just too hard because it was so counterintuitive. And a few years later, I was in a meeting in the US in a bar late at night, and I was talking to these engineers, and they said, we've got this really good robot.
We've got a rig.
A robot, yeah, come and see the robot. And I said, well, yeah. And some of the best tips I get are in bars late at night. But anyway, I went down the next day and had a look at it and sat on it. It was a prototype robot. The original, that was late 90s. And there was a company in California called Intuitive Surgical, which was an absolute startup. They bought the technology from NASA and the Department of Defence.
Because they saw the possibilities.
They did.
Less invasive.
One guy.
Easier to recover, or quicker to recover.
Yep. Well, the big thing was depth perception. So it was a 3D view, whereas laparoscopy, the chopsticks operation, was 2D, so no depth perception, very difficult to sew. This gave you three-dimensional view, 10 times magnified, with intuitive hand movements. Wow. Everything you needed.
So, but this couldn't have been done 30, 40 years ago. The computer technology, the computing power just didn't exist.
The computing power didn't exist, neither did the optics of giving two cameras with a video system in 3D. So wow. that was the NASA.
So it's as if we had to bide our time before the technology could come around. Yep. And what do they say? Necessity is the mother of invention, but he also had to wait for the technology around. So there's one guy said, I've got a robot.
Yeah, this guy, Fred Moll, who's quite a genius. He was a surgery resident. Okay. He wasn't even a graduate in surgery who came up with it. And he's still doing innovative things now in the States. So he started this company. I came back and was like the St. Paul falling off the horse on the road to Damascus, right? As this light came down, I said, this is the way to go. So I got the CEO at Epworth Hospital here in Melbourne, Dennis Hogg, who's quite a visionary.
Yep.
And I said, look,
you need to be brave, you need to be bold.
Yeah, well, he was very gutsy. I said, well, I'll tell you how gutsy in a moment. He said, oh, Tony, you're going to send us broke. I said, oh, no. I said, why don't we go to the States and have a look at the prototypes and then maybe go and talk to a surgeon who's using it. And so he did. And we're talking $3 million in 1999, 2001 actually. Yeah. And Dennis was fantastic because he then saw it and he said, yep, I agree with you. And he took a real punt, real risk, and bought the robot for Epworth in 2002-3 it was.
Now, is this the one that does the heart surgery?
Yep.
Fantastic.
It was originally a cardiac robot. They thought it would be good for minimally invasive cardiac surgery, but in fact, with the beating heart, they couldn't sew the coronary artery. So it was good for mitral valve surgery, but then a urologist in Detroit, Michigan, called Manny Menon said, I think this would work in prostate surgery.
Wow.
And he took it to the operating room.
And revolutionised what we're doing.
Absolutely turned it all on its head.
So what's next for robotics and what's next for the Australian Medical Robotics Academy?
Okay, so what happened was all the surgeons who were training in surgery were still in our public system doing open surgery. Uh-huh. But the robots, because they were so expensive, were only in the private sector. So if you graduated as a surgeon, then you had to go and relearn. This has happened for the last 15 years. Relearn how to use robotics post-fellowship. You should be credentialed to do it all. However, we couldn't be trained. Therefore, there was a problem with the trainers. The trainers didn't know how to teach it. I set up a fellowship system and trained 50 surgeons for a year in robotic surgery in urology. So, but it took a year, and a lot of them have gone back to their home countries and become leaders in robotic surgery, particularly in the UK and in Ireland. I've trained 7 Irish urologists to be robotic surgeons. But so I thought, as I was coming to the end of wanting to be an operating surgeon, I worked out we're not training our surgeons properly, because they have to go post-fellowship and they do a short course and then they start doing it. It took me a long time to become comfortable. So I went and talked to the state government and Mr. Pallas, and he supported us and gave us a grant to...
Some leadership.
He showed great leadership, and I take my hat off to him, and he helped us build the first dedicated training centre in Australia for robotic surgery, which was a linear way of learning how to do robotics. So it was not just a single episode operating on a dog or a
multi-skilling you.
Yes.
Yeah. Have the federal government seen the win and the light?
Not yet.
Not yet. So that's your next journey to try and convince the federal body. to
Yep.
come to the party
So-
and train them from the beginning.
Correct. So I'm talking to the College of Surgeons, and they've been very supportive, and they're the only body that can credential surgery trainees. So we need to work with the College of Surgeons. But what we've just developed is an online training program.
Fantastic.
So you go online onto our learning management system,
A simulator.
and you're right, you're ahead of the curve here, George. We have simulators. So I went to Qantas, and I thought, you know, my father was a pilot as well as a doctor, so I grew up in aviation, and he flew for the Air Force.
Yeah.
But he was always talking to me about safety, and so I actually went and talked to Qantas, and Lee Clifford, who was the chairman of Qantas, helped me with this. I played football with him at the university, so we were good buddies. And anyway, he got me into Qantas, and so I talked to Captain Matt Gray, who was one of the chief testing pilots.
Yeah.
And I went out to Essendon, and I flew in a 737 simulator with
Fantastic.
Matt, and I said, "Now this is a way to teach." And the
This is the way to teach our surgeons.
So when Qantas brought in simulation, they reduced their accident rate by 80%, or incident rate massively.
They would have you say incident rate, not accident
Incident rate.
I know what you mean.
Whatever it is, we call it adverse event rate in
Correct.
surgery.
Even better.
So at the moment in surgery, there's a 17% chance of having an adverse event where you'll need to be re-hospitalised after surgery in 30 days. That's huge, 17%. Costs a fortune. In Qantas, the likelihood of being injured in an airline misadventure is 50,000 times less than it is being injured at surgery.
Wow.
So by simulation,
Yeah.
by introducing simulation in airline training, they reduce their incident rate so profoundly. So that lesson I want to apply in surgery.
Fantastic.
Using the same education, the same simulation training, human factors, and all the things that Qantas teach their pilots in a very low intensity. It's not didactic, it's not hierarchical, it's
Because
not abusive.
the student today is a very different student.
Correct, and
Yeah.
you learn better when
They're
you're
processing differently.
You learn process, and you absorb more when you're not worried whether you're going to get yelled at.
Oh yes. Yes.
So that it's
The tension component is taken out of it. I remember listening to Victor talking to his other surgeons in the operating theatre, and the discussion was anything but whatever they were doing. And I remember talking to him over dinner and saying, if I was recording this, people wouldn't believe what you were talking about. He says, yes, but what you don't understand is what we're trying to do is take the tension out of everything we do, out of our hands, out of our heads, out of our heart, and just do what our training tells us to do. And that's harder to do than people imagine. So that's why they would talk about the latest Mercedes-Benz sports car and how much it was going to cost him to bring it in from Germany, from Stuttgart, or whatever it was. So it was just fantastic. And to hear you say, or almost utter the same thinking, the same strategy, I can see exactly what it means. You take that tension out of the system, allow them to understand the principles and to follow the procedure.
Well, what we want to do is allow the student surgeon to learn away from the live patient.
Yeah.
So
you keep more patients alive.
Or less adverse event, less complications.
Correct.
I'm your friend here.
The man from AMRA is talking, and he is a most friendly surgeon. He has been a great surgeon for the better part of 50 years. Professor Tony Costello, it's been a delight listening to the origin story in the first interview we did, but also getting an idea of not only the creation of AMRA, the Australian Medical Robotics Academy, but where you want to take it next. We wish you all the best.
Thanks very much.